I run the Anxiety Disorders Clinic, which is at the New York State Psychiatric Institute, and it's a research clinic where we were set up in the early 1980s, one of the first clinics in the country, if not the world, to study anxiety disorders. And that meant what are they and how to treat them. And I now direct the clinic, and anxiety disorders, as I'll show you tonight, I'm going to give you a very brief overview of what we mean when we say an anxiety disorder. But my particular expertise is in obsessive compulsive disorder, or OCD, and I'm going to focus on that in the second part of my talk. And on April 25th, colleagues of mine who work in children and adolescents with anxiety disorders are going to come and give you more detail about the first part, which is anxiety disorders in general. And they have started a clinic in Washington Heights, which is to serve the community here of kids and adolescents with anxiety disorder. So I wanted to make sure that they came as well. Does that make sense? So tonight it's a brief overview of anxiety disorders to prepare you for them, if you will. And then most of my talk, I'm going to focus on one anxiety disorder called OCD. In my talk tonight, I'm going to focus on not just what are anxiety disorders and OCD and how we treat them, but why research is so important that I can stand here and tell you about this is because of research. And I'm going to try to illustrate that in the part of my talk on OCD. So I'm going to actually show you some data from our research studies that actually have led to treatment guidelines. Because I actually think what's really important is anytime someone is up here and tells you, oh, you should do this, or you should do that for this disease or that, the only way we know that is because of research and of people who participate in research studies and allow us to test what really works versus what doesn't. Does that make sense? So I'm going to give you more research tonight in the OCD part of my talk to try to give you the flavor of what we can learn from some of the studies that we do that I hope you'll see are actually important to know. So think about what's the difference between anxiety and fear, right? We all are anxious, and in fact, anxiety isn't bad. If you're not anxious, you might not study for a test. You know, your kid might not study for a test if they weren't anxious. So anxiety isn't bad. And if you're actually walking down a dark street and you actually suddenly have a sense of fear, that might actually help you get out of a dangerous situation. But that's different than having a disorder of anxiety, where now the anxiety and the fear has become pathological, and you're anxious about things that actually you don't need to be anxious about, or you're fearful about things that you don't need to be fearful about, and it impairs your life. And my message tonight about anxiety disorders is this. They're really common. They're really common, which I'm going to show you. They're serious because they really impact people's lives. It's not true from the beginning. Yeah, there we go. They're serious, and most importantly, they're treatable. So now I'm going to show you how common they are. Large science study. If we didn't have this science study, we wouldn't know this. People would have sort of said, oh, anxiety, get over it, right, and seen it as not so important. But because of studies like this, we actually know how common anxiety it is. So if you add up all the anxiety disorders, any anxiety disorder, and you look at what proportion of Americans in their lifetime will have one of these disorders, you get to 28.8%, right? Okay. But if you add up all mood disorders, you can see they're important too, but they're actually not as common. All substance use, alcohol, drugs, they're important, but they're not as common as anxiety disorders. Okay. And then there are people who have, all of them. So what it means is if more than a quarter of Americans will have an anxiety disorder in their lifetime, it means we all know, statistically, we all know many people who suffer from an anxiety disorder. So here are all the different names of the anxiety disorders, and so I'm listing them up here. So specific phobia, and I'm going to describe to you the specific symptoms of someone with specific phobia, but think about like that's the person, for example, who has a bug phobia. I've listed these in order of how common these are. The second one that's really common is what's called social phobia or social anxiety, and these are people who are very anxious in social situations. Sometimes it's very specific, like giving a talk. That's called performance only. Sometimes it's in any social interaction. These people can get very, 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 very anxious. Then there's generalized anxiety disorder, and these are the people who worry all the time and can't stop worrying. Then there are people with panic disorder who get panic attacks, which are this sudden periods of intense anxiety that comes on very, very quickly. These people will often feel like they're having a heart attack and will go to the emergency room, but they're not. They're having a panic attack. And people who many people will have a panic attack at least once in their life, but when you get them in a recurrent way so that you start being afraid all the time of where you're going to get your next panic attack, that's panic disorder. Many people who get panic attacks then become afraid of closed spaces, going outside, for fear of getting panic attacks, and that's been called agoraphobia, fear of open spaces, but it can also be fear of closed spaces. Then there's separation anxiety, and we used to think this was only in kids, but we now know that adults can have this too, and these are people who are absolutely anxious about ever being alone, without the person who they feel attached to or comfortable with. And then this other here is to cover things like people can get anxious after they use substances or drugs, or people can get anxious from very specific types of medical illnesses like hyperthyroidism. So we also have anxiety disorders that are due to drugs or anxiety disorders that are due to other medical conditions. And obviously that's important because if it's due to a medical condition, you want treatment for the medical condition, not treatment for your anxiety disorder. I mean, that is the way to treat your anxiety disorder, I guess is a better way to say it. So they all differ from each other in how common they are, what age they start. They're very specific clinical features, right? So someone with social anxiety is afraid of social situations. Someone with GAD worries all the time. You know, so they differ in their features, and they differ not in the big stroke of how we treat them, but in the details of how we treat them. This is just showing you how they differ in how common they are. And so this is the same number I showed you before. This is all of them together. But then this is showing you how they go down in how common they are depending on the disorder. And it's not uncommon for people to have more than one. So specific phobia is a very focused fear. And this is usually you get a real fear reaction. And they're very common. They're common types like animals, heights, right? Mm-hmm. Some people have it to blood or injection or needles, and some people have it to certain situations. This was what I just described. Historically, it was called social phobia, but now we call it social anxiety disorder. And again, I think I already described it. It's fearful of social situations, fearful of being negatively evaluated, scrutinized. Then the worry disorder, right? Generalized anxiety disorder. These are the worry warts who can't stop worrying about this and about that. And it doesn't matter if something goes well in their life. They're gonna worry about something else. It's almost like it's like an engine of worry. Separation anxiety disorder, and this is all this distress about leaving and being alone. Panic disorder, I told you about. Agoraphobia, it can be afraid of being in all sorts of things. These people are people who avoid everything. They don't go do things. And this slide, which again you have, is just to show you if I pick three, panic, social anxiety, and generalized anxiety disorder, and I think about the different possible symptoms, there's similarities and differences. So can all of these disorders have panic attacks? Yes. It's just what you panic to differs, right? These people will panic if they had to come up here and speak to you. And other symptoms that are very common, anticipating with anxiety something that's going to happen and avoiding things that make you anxious. But again, across the three disorders, what makes you have anxiety that you're fearing about to come and what you avoid differs depending on the different anxieties. So for example, social anxiety, you're going to have a lot of anticipation, anxiety about this social situation that you have to go into, and what you're going to avoid are social situations. Whereas in panic disorder, it might be elevators that you avoid. It isn't social situations. Does that make sense? There are often faulty thoughts that people have, but they're going to differ depending on the disorder. So in panic disorder, it might be that you're losing control or you're thinking you're having a heart attack. Whereas in social anxiety, it's this thought that you're being scrutinized and you're humiliated. So the thoughts differ, the physical symptoms can differ, and the typical, what you avoid will differ. So my message is, there are many different anxiety disorders, but it matters which one you have, because that's how the treatment should go. So everybody with anxiety isn't the same in general, and that's the message. So what causes anxiety? So what we know from lots and lots of animal studies and from human imaging studies is that from mice to to rats, to cats, to dogs, to primates, to us, we all have a circuit in our brain that enables us to have the behavior of anxiety. So when I get anxious, my brain is causing those symptoms that you see. Okay. But what we do know is when a mouse freezes, we know exactly the circuit in its brain that enables it to freeze when it's scared. We know that when we take people with anxiety and put them in an image scanner, we have many of the same circuits. So the idea is that if you're a person with anxiety you can't control, those circuits in your brain aren't functioning correctly. That's the problem. So how do we treat it, right? So obviously we want to get those brain circuits functioning, and we want to break that cycle. So there are two ways we treat anxiety disorders. One is with a very specific type of therapy called cognitive behavioral therapy. It's as effective, if not more effective, than medications. It's usually done, not always, but it's usually done in a pretty short period of time. And what you do is you take people who are anxious, you get them to work on their negative thoughts, and you get them to expose themselves to what it is they fear. You do it in steps so people gain mastery. And then depending on the disorder, there are very specific techniques for different symptoms in different disorders. And this is how we usually start with kids. And frankly, it's even a really good place to start with adults. But the other treatment are medications, and there are two big classes. One are medications that affect what we call the serotonin system in the brain, and those include these medications called selective serotonin reuptake inhibitors, and I've listed some of them there. But they also include these medications which are serotonin norepinephrine reuptake inhibitors. I don't know that those details matter, but all of these medications, for most disorders, have FDA approval for the treatment of anxiety. And we don't use them for specific phobia. Specific phobia, we do exposure. And the other set of medications we have are what are called benzodiazepines, which are, a benzodiazepine, if you will, is sort of like a glass of wine. It works on the brain in the same way, and it immediately sedates someone. But we don't use these in general long term. We use these to quickly give someone some relief until these medications kick in, because these medications can take 2, 3, 4 weeks to work. So we use this to get someone less anxious quickly while these medications come on, and then what we try to do is stop these medications, because just like alcohol, these medications, people can become dependent upon them, and people can have trouble with withdrawal. But sometimes we do use these sort of, if this doesn't work as a first pass, sometimes in some disorders we will use these long-term in very specific conditions. And again, there's really good data for all of this. You don't have to feel like no one knows what they're doing. There's many, many, many studies of exactly how to use these medications. So that's the clinic with all the people in the clinic.
There I am.
And our clinic is 18 and above, but the group that's coming does below 18. And I just wanted to say that we have, and we're a research clinic, so we don't do general clinical care, and our research usually comes from the federal government or from philanthropy, and sometimes from industry, but rarely, because the industry often isn't very interested in this. And I just wanted to say there are, and so what we do changes because it depends on the funding we get to run our studies. And there are right now 2 studies going on in our clinic. And obviously, if you call us and you might be interested, the evaluation is at no cost for you, and if you're eligible and come into a study, it's at no cost to you. It's at the end. This one is a study for people with adult separation anxiety disorder, which is no one realized that adults could have this, and this is a medication study. And this is a study which is a sort of an interesting, different sort of study, which is we know exposure helps. We know for anxiety disorders, exposure helps. But some people don't remember, like if you expose them and they feel better, it then comes back. And this second one's a little trickier. Let me see if I can say it simply, which is, this isn't a treatment study. This is about in our laboratory, if we teach you to be afraid of something, and then we show it to you over time so you're less afraid, which is what our therapy does in the real world, how can we help you remember that better? Okay. And so this is a laboratory study to see if we give you something new while you're learning not to be afraid, do you hold on to it longer? Because if that were true, then that would immediately make us recommend to therapists that when you do your exposures with people out in the world, make sure you include novelty. Does that make sense? So this is another example of the sort of biological study that we're doing, but it's intended to improve treatment. But more broadly, if you're interested in this, you can call us and we can give you more details, but more broadly, it's showing you the clinic does treatment studies. This happens to be medication, but we've done therapy treatment studies too. And the clinic tries to better understand what's causing anxiety or how to use what we learn about the body to improve treatments. And that would be an example of a biological study where it doesn't come with treatment, but you get paid for your time and your effort. But in the end, it's all about trying to come back and help patients. Okay, obsessive compulsive disorder. So OCD. Can I see a show of hands? Has anyone ever heard of OCD? So it actually used to be considered an anxiety disorder, and now in a psychiatric manual, it's in its own chapter with a lot of other disorders, which I don't have time to talk about tonight. Okay. So I'm just going to talk about OCD. And the only one that I'll point out before I go on is hoarding disorder. So people who collect excessively in their house. Okay. It used to be part of OCD, but they're now 2 different disorders. Okay. And hoarding disorder is a very serious and big problem, and if you could find me anyone who would want to fund studies on it, we'd love to do it, but we can't find any money to do it. It's a real problem. The problem is that these people don't come for treatment, and the people who see these people are policemen and firemen and landlords and neighbors and family members, and it's a terrible, terrible problem, and it really needs more attention. Isn't it? So OCD. There are 2 important symptoms of OCD, which are obsessions and compulsions. And obsessions are repetitive thoughts or images that someone gets in their head again and again and again. And compulsions are things people have to do over and over again, and they can't stop themselves. Now, we all, every now and then, have a funny little thought that comes into our head. Right? And we've all checked more than once whether we have our car keys or we locked our door. That isn't OCD. These are the symptoms, are really distressing, very time-consuming. I have patients who do this all day long. 6, 8, 10 hours a day. Very impairing in their life as a result. So there are many different types of obsessions and compulsions. There's not just one type. So for example, you can have fears of getting an illness and you're washing all the time. Or you can have fear that you're going to harm someone. So you're checking all the time whether you did. I had a patient who kept thinking he was running people over as he drove to work, and every time he went through an intersection, he'd have to drive around the intersection again and again and again before he could move on. Then there are people who can have sexual thoughts, they are intrusive thoughts, or religious thoughts, and have all sorts of rituals around that. Or there's also the people who they have this feeling as it doesn't feel right. It doesn't feel just right, and they're doing sort of repetitive behaviors until it feels right. So I could tell you more and more, but I won't. The point being is these people have obsessions and compulsions, but their exact symptoms can vary a lot. The important thing is it's not rare. So it's 2 in 100. So schizophrenia is 1 in 100. So most people know schizophrenia. Why doesn't everyone know OCD? Half of the cases start by age 19, with a quarter of the cases by age 14. Half the cases of depression are 32. So unfortunately, this hits people at a younger age. And when you get it, it typically doesn't go away. So once you get it, it's sort of with you, up and down. And if you look at the severity of OCD, unlike all the other anxiety disorders, 85% of them will have moderate to severe symptoms. So it's an anxiety disorder where if you have it, you're likely to have severe symptoms. For example, if you have a specific phobia and you're afraid of snakes and you live in New York City, it's okay, right? But if you have OCD, you can't escape it. Now, specific phobia isn't trivial. If you have a blood injury phobia and you never go to the doctor, that's serious. And I had a patient in the hospital who had a pill phobia, and she couldn't take any of her heart medication and died of end-stage heart disease. So I don't want to say that specific phobias are trivial. They're not. But you can see that this one, the specific phobias range in their severity, whereas this one is just bad. So what causes OCD? So it's the same idea. The brain produces obsessions and compulsions. Just like the brain lets me talk to you, my brain is letting me move my hands. So if I have obsessions and compulsions, my brain is causing that behavior. But that's not the same question as, how did my brain get like that? Does that make sense, the difference? Again, what causes obsessions and compulsions, the behavior, we think, again, it's certain circuits that aren't functioning the way they should. This is a diagram of the brain showing one of the circuits that is thought to be involved. And again, we know that because of science. We know that because we can now image the brain and compare people with OCD to people who don't have OCD, and we can see these areas of the brain that are in blue are hyperactive. And I promise you, if we didn't have science, people would say, "Oh, you're making it up," right? That's what they do to psychiatric illness. Like, so if we didn't have science to show something's going on in the brain, I couldn't be able to say to you, this is a real disorder. These are serious disorders. And again, that broad picture, like other anxiety disorders, we treat it with that therapy, and we treat it with medication. So these are the medications. Again, those serotonin reuptake inhibitors. These are the ones we use. And here again is this cognitive behavioral therapy, but of a very particular type with some very specific features. We wanted to ask, so what's the better treatment for OCD? Is it the medication? Is it the therapy? Or is it the two together? So this is a study that the National Institutes of Mental Health funded that we did here at Columbia with a colleague in Philadelphia. So don't be scared, but this is a data slide. So this is a scale of how bad is your OCD, and higher is worse. And the blue arrow is above that blue arrow, we usually recommend treatment. And you can see this is where the patients came in. So they had moderate to severe OCD, and they all got treatment over 12 weeks. And what I'm showing you is that in yellow are the people who got a sugar pill. And why do we do that? It's to control for time and attention and support, because maybe that would be enough. Was it enough? Right. It's flat, right? The line didn't change. So here in red is the medication.
Okay.
So you can see there was a slow decline over time that took out to about 12 weeks for the medication to work. But I want you to look at the last two lines. So these are the therapy alone or the therapy with the medication. And the therapy was delivered very intensively over that first month. And then they got booster sessions over this. So that's what I mean by the therapy can be very effective. But these were very skilled therapists. The therapy was delivered in its optimal way, which was every day for 3 weeks, 5 days in a row. And these patients didn't have a lot of other stuff other than OCD. So you change any of that, and you won't get results like that. But I think it's useful to see how effective the right therapy can be, which we know has now changed the brain, because you're no longer obsessing and compulsing in the same way. Now, unless you live near us and we're doing one of these studies, it's hard to get this high-quality therapy unless you've got a lot of money and can go to someone in private practice. And it's a real problem in the field, although now people are getting really interested in using technology and the internet to deliver this therapy to make it much more accessible and cost-effective. But therapy is like an exercise program. This type of therapy is like an exercise program. It isn't going and talking to your therapist. It's your therapist is teaching you how to expose yourself and teaching you how not to do your rituals. Okay. And if you don't adhere, you don't get an outcome like this. Most people still get medication as their first treatment because the medication you can get from anyone. You don't have to come to a psychiatrist to get the medication. Mm-hmm. Your primary care doctor will give you the medication. But what you can see from this curve of medication is while they're better than when they started, okay, if you notice, that's still above that blue arrow. Mm-hmm. So that's typical for OCD, which is the medications, they vary. For some people, they really take down their symptoms. Some people, they don't touch at all, and most people, what they get is a reduction, but as you can see, on average, their symptoms haven't gone away. So if you were obsessing and compulsing 6 hours a day, and now you're obsessing and compulsing 3 hours a day, what's good is you have 3 more hours, okay. But what's bad is you're still obsessing 3 hours a day. And what we know is it's really the goal is to get people well, as minimal symptoms as possible. Those are the people who don't relapse. They're less likely to relapse. So the whole field wants to get people as low as possible, and that isn't it. No? So what can we do? So that was the next study that we did, is what in general the field did is they added medications called antipsychotics, which have been used in schizophrenia and which have been found when added on could help people. But what we knew from these other studies was they only really helped about 1/3 of people. It now means you're taking 2 medications, and these medications have a lot of side effects. And the longer you're on them, the more risk you're at. And we have OCD patients who start getting ill in their adolescence and young adulthood. So because we got such good results with the therapy, we wondered, well, if you have patients like this who come to us with partial symptoms, even though they're on an SRI medication, we could add antipsychotics, or maybe we could add the therapy then. So luckily, the National Institutes of Mental Health thought that was a study worth funding. Okay. So that was the next study we did. So now these are people, remember that blue and above, you should get treatment. And now we have people with OCD, but they're all already on a serotonin reuptake inhibitor, and they've been on it for at least 12 weeks, most for 6 months or more. But look at how much symptoms they still have. So it's a slightly different group of patients, if you understand that. These are people who still have symptoms despite being on medication. So now, some of them, we give them the therapy, and you can see the therapy helps. If you add it then, it helps those people. Mm-hmm. Yellow is if we gave them the pill placebo, and the real surprise here was the red line. The red line is if you gave them the antipsychotic. We expected that red line to be here, but what you can see is antipsychotics really are not very good. So my message is this therapy is really good on its own, but when optimally delivered, and that's a problem. And it's really the best thing to get if you're on medication and still have symptoms. Much safer than the antipsychotics. But just to leave you with what we know, and we know this from the research, this is the only way we would know it, is that for OCD patients, serotonin reuptake in medications, many respond, but the response is usually partial, right? They're going to have less symptoms, but in most people, the symptoms aren't going to go away. Okay. So we're studying other medications, and we're also trying to develop new treatments. And then for the therapy, we know that many respond, but how do people access it? Can patients adhere to the treatment? Because it's hard. If you're terrified of touching, the poles in the subway because you fear of contamination, it's really hard to go out and be doing that. It's not an easy treatment. So we've been working with a group looking at the internet to deliver CBT to increase access. And that novelty study that I told you, it's a way of how can we improve the exposure therapy, different ways of how can we make this therapy even more powerful. And then we know that if we give the two best treatments together, not everybody, but actually some will become well. And as soon as people become well, the first question they ask us, can I come off my medication? So luckily, we've been funded by NIMH, and that's the study we're doing now. And our sense is some people can, and some people can't. And the goal of this study is to try to, can we figure that, instead of just doing that by trial and error, can we figure out who can come off and who can't, and figure that out using science, so that then we can actually make recommendations to the field for how people should do this. So that's the OCD team, which was inside that bigger team. But these are the people who focus on OCD.